patients along with nephrology. And then we have to discuss with the patient the need for temporary or permanent hemodialysis. So we have to tell them that, you know what, if we don't manage to do it, then you're going to need permanent hemodialysis. And in this case, also was also plays a tunneled line before the operation. And of course, if their kidney function is not great, if the GFR is at less than 20, that probably it's too much of an operation to do when there's not much to save. It's a very long operation. It could be dangerous, of course. There are complications. Main one would be urinary leaks that you can get. So if we don't think they're going to benefit from a long operation, of course, we'll go for something simpler. And the approvals, the approaches that we use to use would be either the open, robotic, or laparoscopic. That depends on the surgeon, how you're going to try to do partial nephrectomy or the nephrectomy in general. And in the laparoscopic or robotic, often we would mark the patient. So I would reimplant the kidney as a normal kidney transplant. So I would go in the right iliac fossa. So I would do my incision before they start the operation. And that's the incision that they would use to take the kidney out. So I will use the same incision. So you don't have to make an extra incision for the extraction of the kidney and the implantation. I will use the same one. And I mean, that's mainly for England. That shows that how many of these cases, how many tumor nephrectomies would be the cause of renal replacement therapy. And that's what we were kind of targeting as a system, trying to minimize the patients that will go on the dialysis. And that's because, of course, the cost is very high to dialyze people, and the quality of life is not great. And I mean, these people most likely would go for hemodialysis, not peritoneal dialysis easily, which is probably better tolerated by most dialysis patients. There's also a mortality rate, which is pretty high, that the dialysis people would have. And also, on the other hand, if you were considering to refer the patient for a transplant, then in most cases, I mean, you would have a 2 to 5 years disease-free survival on dialysis before they are eligible for the transplant. So it's not easy to refer them straight away, being a nephric, and say, okay, let's do the transplant now. We have to wait and see whether there's going to be any recurrence or not. And I mean, that would be some cases that we would do. Huge tumors. You can see the stretch of the left renal artery, and then some other scans. So these would be cases that we would try at least and do as an autotransplant, because there's no way probably to take this tumor out in the body. You can see how massive it is. And this is a case that I can show you what we did in this. I mean, you can see how big the tumor is. It's going throughout the whole kidney. And at least it's lateral to the kidney, most of it, but it does get in the hilum. So that will be a very tricky scenario to try and do a partial nephrectomy in the body. So we aim to go straight for the ex vivo partial nephrectomy. And that's what we got when we went on the back table. So you can see the kidney here is flushed. We use UW to completely flush the kidney straight when it comes out, and then cool it down to make sure that we get the best kind of viability from the tissues. And then what we normally would do after that, we would skeletonize the vessels, find the arteries, see where the arteries go. I mean, we use the CT scans, the CT angiogram, to know exactly where the tumor would be and try and minimize the damage to the remaining of the kidney. So if the artery is nearby and been pushed away, of course, you're going to try and preserve it. If there is an artery going straight to the tumor, of course, we're going to ligate it. And so we use the angiogram, and also we use the on-table ultrasound to mark our area and see where is best to cut the skin, how to extract this tumor. And you can see the arteries, the vein being already skeletonized, and the ureter being preserved. So some back table work. I mean, I would normally do it with urology over there, or if there were two of them, they would do it together, slowly taking the tumor out while trying to ligate the vessels that are obvious during the extraction. We can use some small clips, or we can use ties. and safely take the tumor out. I mean, you can see what's left. Sometimes it's tricky, and you think that there's nothing left of the kidney. But it's a pretty remarkable organ, as you all know, and in most cases, it does wake up straight away and starts working. So here you can see how big this tumor is after its resection. We go deep in the kidney. And here is when we're starting to do the reconstruction. So the reconstruction involves taking the vessels, the arteries, putting the arteries together, and reconstructing everything, artery, vein, and collecting system. I mean, of course, for the others, we use 6O or 7O proline, same for the vein. And for the ureteric system, I would use PDS 5O or 6O to reconstruct it. A smart trick that we used over the years is to use propofol. So I would ask a propofol vial from anesthesia. They would give it to us, and then I would put it in a syringe with a metal tip, and then I would give it through the artery. So I give it through the artery, and then I check the raw surface that we've cut and see, do I have any remarkable leaks? If you can see a big leak, it's better to fix it and not wait for coagulation. Same for the vein, same for the collecting systems. I would check all three vessels with the propofol and see, do I have any ongoing significant leaks? Because, I mean, if you leave something big, the fireworks are pretty impressive in there. And then, as you can see here, we started fixing the kidney, trying to put things together. And then we close the kidney as you would do in a partial nephrectomy. We put some Serogel inside, some other clotting factors, and then we close it with some PDS sutures on top. And that's the kidney after the reperfusion. So the implantation for us is the same as we do the kidney transplant, minus the immunosuppression, of course. And so we mobilize the same vessels, the external iliac artery, external iliac vein, and that's where we implant the kidney. Sometimes the vessels are very short. It can happen, especially with right-sided kidneys. So it could be a very technical procedure. But I mean, it's extremely rare to say that we don't have enough vessels. We mobilize the arteries and veins as much as we can in order to achieve this. And in most cases, the ureter is enough to reach the bladder. If there's an issue with ureteric length, then we can do a UU and again achieve drainage for the kidney. And here's a CT scan after the autotransplant. You can see it's half a kidney there. And you can see the ureteric stent that we use between the kidney and the bladder. So, and sometimes it's pretty impressive that there's not much of a kidney left, but these patients remained dialysis independent. And This will be some of the outcomes. I mean, there's going to be a paper coming out soon for this, and these are some of the data that we collected while we're doing this. And I just wanted to show you what kind of cases these were and what kind of complications, of course, and the complexities we had. So for this study, all the patients were patients with complex tumors. So the other cases, let's say the ureteric ones, or chronic pain and everything, of course, they are a lot easier to manage and a lot more straightforward as an operation with not many complications. The complications would come for these cases where you chop the kidney and then you try to put inside what's left of it. So we had 33 cases that we observed over the years at the mean age of 64. Vast majority of them would be solitary kidneys. Of course, there are other cases where the contralateral kidney was not great, and sometimes we would also have bilateral tumors. But mainly solitary kidneys, I would consider it. We had a tumor size of 6.3 up to 18. There were some smaller tumors as well, but this will be very hilar. They will be very close to the hilum and very difficult to safely do the partial nephrectomy. Most of them were single tumors, but also there were some others with multifocal disease that we tried to attempt. These 33 ones are the ones that we managed to do as a kidney autotransplant. We had a total of 50 cases for this series. And of course, some of them we could not safely reconstruct or we could not safely put in the body again. And for example, one of the tests that we do to achieve this is then after the reconstruction, I would give lots of UW or special fluid in the artery and see what comes from the vein. If there's nothing coming from the vein, then I wouldn't even attempt to put it in. It's going to explode. So, small kind of things that we would do to make sure that, we're going to benefit the patient by what we do. Of course, we spend the time to try to do the autotransplant, but if it's not going to be beneficial, it's going to be too risky, then we would not go ahead. The renal nephrectomy score, as you can see, the vast majority of them would be highly complex. And these are the cases that we have to consider for an autotransplant. Not every case. That's the exemption. When it comes to operatives, long cases, there would be long cases to do. And I mean, the back table could easily take 2 hours. And just trying to take the tumor out and trying to reconstruct the vessels inside. Transfusions had about a third of the patients, and the stay will be about 16 days, the average one. GFR change. So the impressive thing about these cases is then when you take the tumor out and you put the kidney back in, the GFR improves, and in some cases it's pretty remarkable. You see a good increase in the GFR, obviously because there's no obstruction now inside of the kidney and there's no immunosuppression to cause the vasoconstriction of the vessel. So these kidneys do great. Once you put them in, they actually improve. So the patients will get better kidney function than they had before you did the autotransplant. 70% of the cases were clear cell. Some other less common types that we would use, but clear cell is the main one to use. And when it comes to T stage, I mean, most of them would be T3. So that will be indication for T3 tumors straight away because of the involvement of vessels. Smaller tumors were also involved, but that had to do with location, not the size of the tumor, was the location that led us to do the autotransplant. There were positive margins in 6% of the cases. And of course, that happens because you're trying to save the kidney parenchyma. So you try to save as much as you can because you want to have a good number of nephrons and keep the patient dialysis independent. And I think there was a case, not the clear cell. The clear cell is very nice and easy to take the whole capsule out, but there will be some other cases, and some of them that had multiple tumors. So that will be trickier to try and do zero resection. Dialysis needed in almost half of the patients, but that was temporary dialysis after the case, especially if it was a long case with lots of IV, then you would do the dialysis to improve the patient. Just waiting for the kidney to open up. Complications, of course, half of them would have complications, and the commonest one, of course, there would be bleeding while you reperfuse the kidney. That would happen, but post-op, some of them could have a collection, and in some of the cases, that would be mainly urinary leak, and that's because of all the cuts on the parenchyma. All of them will get a stent, a ureteric stent that we keep there for 4 weeks, and also we would leave a drain anyway. So the drain will be there. Take into account that there could be some leaks anyway, and just make sure that the urine comes out. 30-day mortality was 6%. So 2 of the patients died, and both of them were from a PE. Long cases, I mean, old patients. So that's the complication that happened to us a couple of times. When it comes to long term, I mean, we observe these patients for a long time. Some of them 44 months. And they have a very good cancer-specific survival. So we were up to 96% that they did not have any problems over the years. And the recurrence-free survival was 79%. So, so in most cases, I can see if you're do the careful selection of cases, then you can get really great results for them, and they do not get any problems from these tumors for almost lifelong. So, and dialysis-free survival is the 82% of the patients that were still alive. So, although they were most of them will have just one kidney, and that's not the whole kidney, just part of the kidney returned to them. 82% of them will remain dialysis free. And that's what we're trying to achieve, trying to make sure that they have good quality of life, no need for dialysis. And, of course, if you want to avoid a transplant with all the medication involved and the impact that that could have also on your tumors and everything, then it's better to go with the auto. So, and what we learned over the years is that the auto transplant maybe not be the best option for the multifollicular genital tumors. I mean, I remember some cases with von Hippel-Lindau, and yes, I mean, you kept cutting in the kidney, you would find more and more tumors that you could not even see on the CAT scans. So maybe that's not a very wise thing to do, to just remove a big tumor and put it back in with the rest of them being present. So the RCCs are the best one and the easiest ones to remove. If you do develop a urinary leak, just have to be patient. Make sure you have full removal of the fluid with a drain. Make sure there's not a big collection inside. And then with time, the kidney will heal. You make its own scar tissue. So there's not much to do. I mean, we will never attempt surgically to stop it. It's just a matter of waiting to get the urinary leak and send the patient home with a drain, of course, if needed. And the kidney is a remarkably resilient organ. I mean, in most of these cases, it's pretty astonishing how much of the kidney you can cut, and still the kidney will work well. So yeah, lots of this photo we had. And now when it comes to the ex vivo partial nephrectomy, of course, it's a complex and it can cause lots of complications, but is the best way to get some renal preservation without compromising cancer control. And also, it's a treatment that we could consider in selected patients, not everybody. These are cases that you need to patient, first of all, to be fairly fit for a long operation, and also that the patient wants to go for it and accept the risks. Of course, it's always a decision with the patient. I mean, we can try and save your kidney, but you might have a complication, but we might have a recurrence and we have to need to have another look. But on the other hand, you will not need dialysis. And because they could not even go for the transplant straight away. Of course, we keep an eye on the cancer and see whether we have any recurrence over the years, especially after 10 years. Some of the patients that would reach, we want to see what would be the 10-year survival when it comes to cancer-specific cases. And of course, the partial nephrectomy is something that happens more and more. And I assume now with the robot, more people will try and deal with very complicated cases. But on the other hand, I mean, we keep this as a kind of a backup. And as I said before, based on the algorithm we followed, I mean, my colleagues would always go ahead and try and do partial nephrectomy. But if there was problem, if there was bleeding, if they couldn't do it, they would just call me. They would do the radical nephrectomy. I will take the kidney out, flush it. So at least we had the option to work on it on the back table and see can we save it and put it back in. Thank you.
Any questions for Dr. Vrakas?
Dr. Vrakas, this is Robert Marino. I do mostly stonework, but I'm just fascinated by your presentation. It's just very interesting and admirable.
Thank you.
I had a question about your use of nephrometry that you mentioned there.
Mm-hmm.
And since you came here to Gainesville, I presume, I just wondered if you could elaborate on what tools you use. Do you use Visage, or do you have another software that helps you to do the nephrometry? Can you elaborate on that?
I mean, thank you for your question and for your kind words. I mean, these are the ones that the study that we did in England when it comes to the nephrometry scores. So over there, it was provided to us by radiology. Is a different system. So here, I mean, we've done about, so besides the ones I presented, which are all kind of England experience, we've done another 14 cases here in Gainesville with urology. Out of these 14 cases, I think there were two that we did for this kind of complex tumors. And one of them were about 10 days ago. That was a big tumor in the hilum. So I don't think we used the nephrometer from the ones we've done. And it was just based on the urology experience that they cannot come out. And they were hilar. I think I might have some also photos to send you to show you. Let me see.
Roberto, there are these systems were developed to assess the complexity of partial nephrectomy. And a nephrometry score is one. There's another score called PADAU, PADAU, and there is a third one as well. So there are multiple scoring systems just to quantify the complexity, whether it's endophytic or exophytic or a combination, how close to the hilum, what the size of the tumor is, and those kind of factors go into it.
Thank you. Yes, I appreciate that a score is given, but I presume that furthermore, a good amount of thought is gone into the images to try to plan your operation and understand where you're going to be operating. Is that correct, Dr. Vrakas?
Correct.
And I was wondering if you could elaborate on how you do a little bit of that work and whether the radiologists get involved in doing some post-processing images for you for the location of the tumor and the size of it and things like that.
I mean, it's mainly my urology colleagues here that would do this. I don't think they get radiology much involved. So if urology thinks that it will be too dangerous to do the partial in the body, then that's how I would proceed. Of course, we can use the metrics and the scores, the different scores, but I think it's mainly the colleagues' kind of experience that to say let's not try and do this. And in the case I do here, it's actually urology that comes to do the partial nephrectomy. So they come all together. I mean, they had a lot more experience than me in a partial nephrectomy. So they come. I mean, I remember last week we had a bit of a disagreement, very friendly one. Of course, how to get the hilar tumor out, because I would probably try and follow the vessels from the hilum up to get the tumor. So try and get the tumor from the hilum. But my colleagues were saying, no, we're going to go from this line from the back. It's pretty, how can I say, it's a pretty bloodless kind of line that we can follow and get to the tumor. And that's what we did. And it was remarkable that the kidney did not bleed after reperfusion, despite the huge cut we had on it. So I'm mainly based, of course, on urology expertise to do the partial nephrectomy, and they do it with the ultrasound on table. But once you locate the tumor, and of course we study the CT angiogram to know the arteries going around it, then you know which plane to use and avoid any surprises.
Thank you. Thank you very much. Very interesting.
Thank you.
Dr. Vrakas, I'm Thomas Metzner. I'm one of the urology residents, and I'm actually sitting in a room here with some of the other residents, our fellow and a medical student. First of all, thank you so much for coming and speaking with us. This is an incredibly fascinating talk, just to conceptualize that this is even possible in the interest of treating renal cell carcinoma. So thank you so much. And I have two questions. Number one, I was wondering if you could comment on the use of propofol when you're perfusing the kidney.
Yep.
What exactly that buys you? And then second, I was wondering if you could comment on the use of renal mass biopsy, if you utilize that, or if your urology colleagues utilize that in making decisions, because presumably some histologies would be we potentially consider more aggressive treatment versus less aggressive treatment, and if you could kind of discuss how that plays into what is ultimately a multidisciplinary surgery, essentially.
Yeah, thank you very much for your question. So the propofol is something developed after, most places will use methylene blue to do this. The problem with methylene blue is that it stays in the tissues for a long time. So once you use it, then everything is blue. So then you cannot easily see where, the leak is coming from. So, I mean, normally I would start, let's say, with the artery. I would get the propofol straight on with the syringe and just give it through the artery. And then I would check from inside the parenchyma, see what's going on, and if I have any big leaks or just minor leaks coming from the parenchyma and not a proper vessel. And if I see something, I'll try to repair it. If I can preserve the artery even better with some stitches, sometimes you might need to ligate it or kind of oversaw a stump if you've cut something. Same with the vein, same with the collecting system. And of course, when we give the propofol, we have high pressures inside. So if, for example, if there's a collecting system injury and only you can see some propofol escaping at a high pressure, you know that this is pretty safe to heal. So because you're going to have a stent inside anyway. So that's what we use with the propofol, and it works pretty well. And the good thing is you just tap it with a Raytec, whatever, and all the white goes away. You give some more, and you see you kind of reproduce what you want to do. Now, biopsy-wise, not all the cases will get the biopsy. I think they try. I mean, for example, you can do the biopsy. It makes probably the nephrectomy more difficult if you do that. And it depends also where the tumor will be and whether it will be easy to do the biopsy. So, from what I know, not all the cases will get a biopsy. Some of them will be based on radiological criteria, if they can use or some background. And as we mentioned in the presentation, if it's multifocal tumors, then maybe yes, we shouldn't consider this as an approach. We tried several times, but it's very difficult to make it work.
Okay. Dr. Vrakas, so half the patients need to be on hemodialysis after this procedure for a brief period of time. On average, how long are they on hemodialysis before the kidney function recovers?
I mean, most of them will be 1 or 2 sessions, so it wouldn't be for long. And I mean, over here in Gainesville, yeah, of course, the 14 cases we've done here, only the 2 will be these kind of cases, and they didn't need any dialysis, the 2 of them that we did. Of course, the ureteral strictures are a lot more straightforward, so none of them needed any dialysis. But I mean, these cases, some of them will be some really extreme scenarios as well. So that's why half of them would it could be a soft call sometimes, to be honest, but in most of them would already place a tunnel dialysis catheter. So if ICU wanted to dialyze them to improve their fluid status, we wouldn't have any problems for that. And once the kidney kicks in, then we can take the line out and not have any issues longer term.
Yeah. The other comment I heard you made was if the eGFR is less than 20, then it may not be worth pursuing this. Is that your current thinking as well?
It's a good question because we've already broke this rule over here. So the tumor that we did here, I think the first case that we did, it was a lady with a GFR around there. It was 2022 or something. But she was pretty adamant herself that she wants us to do our best. So she doesn't need any dialysis at all. So she had 1 kidney, not a great GFR. And I mean, we thought we were going to give it a go. Since it's the patient's kind of opinion as well, and she would consent to everything, regardless of result. And we did go ahead and we did it. Uh, it's a tricky decision. I think it depends on the patients and what are the patient expectations. And if they're pushing too much and they say, I don't want any dialysis, I mean, a GFR of 20 in the absence of immunosuppression can take you for years sometimes. It can, be a benefit for years. So if someone is older, yeah, I can see the benefit from this, to be honest.
Yeah, because that's a shift in thinking now, isn't it? People even with very low GFR trying to keep them off dialysis as long as they don't have any major electrolyte or fluid issues. So just raise creatinine alone, the body is able to tolerate it. And And yeah, because that's one thing that we have, we haven't done that many of those, but a couple of cases I've been involved in, and do Dan Rutgers in our transplant program, and our transplant did the auto transplant. We did choose patients with lower GFR, and sometimes it went down to as low as 10, and then we kept them on dialysis, and they gradually bounced back. And it really, because it helps them to keep off dialysis. So that's a wonderful benefit from this.
Correct. I agree. Yes. I mean, we can push as much as the patient can take it, actually. So
Yeah.
it depends.
Thank you, Ruckus. And any other? Yeah.
I have a question. Hi, I'm Mark Bandick, one of the urologic oncologists here, and this is thank you very much. It's an excellent talk. But I had some experience with this as an intern a long time ago in Pittsburgh when they were doing auto transplants and transplant. It was a big transplant facility. But I think I may have work for you. I have a problem that was sent up from Palm Coast, a 62-year-old lady with a GFR of 20, and her dominant kidney has a growing 6 centimeter mass. And I really actually just had a long talk with her. Also, she's being followed by nephrology, and they're talking about dialysis, but it's not yet. But then certainly, this would be too big for me to do as a partial, and so. I need your address
Yeah,
and see if
definitely.
you would take a look at this lady, and what you would need. No, she's had imaging studies that were done outside, but this may be one for you to take a look at. And what a timely
Yeah.
the conversation and meeting this has been. So that's a problem. So what do you think, Doctor?
Yeah, definitely. I mean, we can look at this. I mean, we can get to the urology MDT and see what they recommend. I mean, yeah, the good thing with having us transplant on site is that, they can even try and do it. And if it doesn't work, we can go ahead with a partial. But if she's willing to take the risk of a longer operation, then probably it could probably worth trying to save that kidney and spare her the dialysis. That's one of the scenarios that we can push sometimes.
Yeah, that's where we're really at on that, whether to surveillance this thing, but it's growing, and at the same time dialysis. So it's really, I think that's but she has some diabetic, morbid obesity, the usual things that we see here. But maybe something for you to consider. I appreciate your time and expertise and adding this to what we need in this situation where we have multiple comorbidities and large renal masses that we don't know what to do with. And you really have filled that space. And thank you for all your expertise.
Well, thank you.
Dr. Akas, the other question for you is, are we able to do this totally robotically, both extubative as well as renal transplant?
Not yet. I'm working on it. I'm working on it.
Yeah.
I've started. I mean, yeah, I was not trained on the robot, but I've started my training already. And yes, that's my next target to do the implants with the robot. But I still have to go and learn how to specifically do the transplants. I mean, doing especially the ex vivo resection of tumor, I wouldn't easily try the robot, to be honest, because sometimes if you don't have good hemostasis, then the bleeding is pretty impressive. I mean, if it's just a ureteric issue, that's easier. Of course, it's just transportation of the kidney rather than transplantation. But if there's a big cut on the kidney, I'm not sure it will be easy to control. But I mean, we're going to start doing it for normal transplants, and then probably, with growing expertise, we can do more and more.
Yeah. The way I was envisioning this was we do robotic nephrectomy, we take the kidney out. I mean, that we do commonly. And then we do the ex vivo portion. And then when you put it back, we do it like a robotic transplant, which is now being, it's not becoming an uncommon now. It's probably the way of the future. There are a lot of large studies that have shown favorable intermediate term results with the robotic renal transplant. So So I think that this would provide that great opportunity for us so that we can try and do all these minimally invasive.
Correct, correct. No, no, I couldn't agree more. So, and especially for high BMIs. I mean, that's my target here because we do BMIs 40, 45 easily.
Yeah.
If someone is slim, I make a tiny little incision for the transplant, so it doesn't worth it.
Yeah.
But if it's a high BMI and everybody gets a wound infection at the very end, and some would have a nice dehiscence everywhere.
Yeah.
So in these cases, it's better to benefit from a small incision with a robot. So yes, that's what I'm trying to work on here.
Okay, that's great. Thank you. Is any other questions for Dr. Vrakas? Okay, hearing none, Dr. Vrakas, thank you so much. This has been very enlightening, and we thank you for your service. These are very hard cases. It takes really a dedicated surgeon to pursue a career like this. Thank you for doing this. I appreciate it.
Thank you very much for having me. Thank you.
You're welcome. Thank you.
Thank you, sir.
Appreciate your time. Thank you.
Thank you. Thank you. Good morning.